I'd like to thank Dr. Ramaiah for putting me in all these fights. Here are my disclosures. So again, this is I was hoping I'd have a little breathing room to reintroduce this same thought, but it is what it is. So yeah, there's no level 1 evidence for randomized control trials proving one manufacturer's stent graft for AAA is superior to another. And I know that we had a Cochrane review a few years ago that substantiated this fact. A moment ago, you saw me show this. And so I'll just kind of double down on this. This is going to be a quick talk, by the way, because sometimes this particular talk can be a little bit of a commercial, and I wanted to avoid that. So we know that there's level 1 evidence from the Imperial study and other supportive sub-analyses regarding Eluvia versus Silver PTX, yet it really hasn't had a huge impact on how vascular specialists decide which device they're going to use. I also showed this on my talk here about just the myriad of stent choices that we have to treat PAD, yet it doesn't really seem to jibe in my mind in terms of something that has level 1 evidence and other compelling registry data like Supera and whatnot. There's definitely other forces at play is what I'm trying to say. In terms of the evolution, this is a very famous slide, and I've kind of thought of the wire and fabric age as being over since I'm a big fan of the Ovation and the Alto products when they came out back in 2000 and maybe 2011 or so, because I was really starting to see my own patients start to come back from issues regarding the neck enlargement and type 1 endoleak, and we continue to see that to this day. So while there's no level 1 evidence to say, well, which one's better, I think this gets about as close as we're going to get. And so this is the VQI Vision data, which was, I think, mentioned earlier in the morning. And basically, it's looking at device-specific risk long-term for reintervention with primary outcomes looking at having to do reintervention as well as the statistics regarding late rupture. And secondary outcomes talking about conversion to open aortic repair and survival. Unfortunately, we only get 4 flavors here with the excluder, the endurant, the zenith, and both varieties of the AFX, meaning the, I guess Gen 1 and then the one that was fixed. And so you can see in this particular graph the reintervention rate, and you can see the AFX varieties, the zenith, and the excluder being arguably maybe the most stable device over time. You can also see that in the late rupture data. All of that holds. So when this came out, I thought it was very compelling, and I'm not entirely sure, hearkening back to my earlier slides, did this change our utilization patterns? So again, while AAA device selection is highly specific to the patient and to the experience and to the contractual obligations of your hospital and whatnot, I will say that what never gets spoken about are all the beautiful people outside wandering about as our device representatives that make this event possible. So I'm going to be very gentle in how I say this, but there is a substantial role in the way that they influence our use of these devices, and it doesn't get spoken enough, and there's no science to kind of be able to cover that. But again, the influence here extends obviously beyond purely clinical considerations and have an implication regarding everything that we do for surgery. And as we always end these talks, we really want to have high-quality randomized controlled trial studies. But that being said, in a tongue-in-cheek way, well, we do already have level 1 evidence for some things that we do, and it's not making a difference. Thank you.